Lewis's Medical Surgical Nursing, 11th edition, Chapter 11, Inflammation and Healing. This chapter focuses on inflammation, wound healing, and pressure injury prevention and management. Maintaining skin and tissue integrity is a key nursing role. Multiple concepts are closely related to tissue integrity. Adequate nutrition and perfusion are essential so that the body has the necessary factors to promote healing when injury occurs. Impaired mobility and sensory perception increase the risk for injury. When injury does occur, pain and problems regulating temperature and fluid and electrolyte balance are common. Inflammatory response. The inflammatory response is a sequential reaction to cell injury. It neutralizes and dilutes the inflammatory agent, removes necrotic materials, and establishes an environment suitable for healing and repair. The term inflammation is often incorrectly used as a synonym for infection. Inflammation is always present with infection, but infection is not always present with inflammation. However, a person who is neutropenic may not be able to mount an inflammatory response. An infection involves invasion of tissues or cells by microorganisms, such as bacteria, fungi, and viruses. In contrast, heat, radiation, trauma, chemicals, allergens, and an autoimmune reaction also can cause inflammation. The mechanism of inflammation is basically the same regardless of the injuring agent. The intensity of the response depends on the extent and severity of injury and on the injured person's reactive capacity. The inflammatory response can be divided into a vascular response, cellular response, formation of exudate, and healing. Figure 11.1 shows the vascular and cellular response to injury. Vascular response. After cell injury, local arterioles briefly undergo transient vasoconstriction. After release of histamine and other chemicals by the injured cells, the vessels dilate. Chemical mediators cause increased capillary permeability and facilitate fluid movement from capillaries into tissue spaces. At first, this inflammatory exudate is made up of serous fluid. Later, it contains plasma proteins, primarily albumin. These proteins exert oncotic pressure that further draws fluid from blood vessels. Both vasodilation and increased capillary permeability are responsible for redness, heat, and swelling at the site of injury and the surrounding area. As the plasma protein fibrinogen leaves the blood, it is activated to fibrin by the products of the injured cells. Fibrin strengthens a blood clot formed by platelets. In tissues, the clot functions to trap bacteria, prevent their spread, and serve as a framework for the healing process. Platelets release growth factors that start the healing process. Cellular response. Neutrophils and monocytes move from circulation to the site of injury, figure 11.1. Chemotaxis is a directional migration of white blood cells, WBCs, to the site of injury, resulting in an accumulation of neutrophils and monocytes at the site. Neutrophils. Neutrophils are the first WBCs to arrive at the injury site, usually within 6 to 12 hours. They phagocytize, engulf bacteria, other foreign material, and damaged cells. With their short lifespan, 24 to 48 hours, dead neutrophils soon accumulate. In time, a mixture of dead neutrophils, digested bacteria, and other cell debris accumulates as a creamy substance called pus. To keep up with the demand for neutrophils, the bone marrow releases more neutrophils into circulation. This results in a high WBC count, especially the neutrophil count. Mature neutrophils are called segmented neutrophils. Sometimes the demand for neutrophils increases to the extent that the bone marrow releases immature forms of neutrophils, bands, into circulation. We call an increased number of band neutrophils in circulation a shift to the left. It is common in patients with acute bacterial infections. See Chapter 29 for a discussion of neutrophils. Monocytes. Monocytes are the second type of phagocytic cells that migrate from circulating blood. They usually arrive at the site within 3 to 7 days after the onset of inflammation. On entering the tissue spaces, monocytes transform into macrophages. Together with the tissue macrophages, these newly arrived macrophages help in phagocytosis of the inflammatory debris. The macrophage role is important in cleaning the area before healing can occur. Macrophages have a long lifespan. They can multiply and may stay in the damaged tissues for weeks. These long-lived cells are important in orchestrating the healing process. When particles are too large for a single macrophage, macrophages accumulate and fuse to form a multinucleated giant cell. Collagen encapsulates this giant cell, leading to the formation of a granuloma. A classic example of this process occurs in tuberculosis of the lung. When the Mycobacterium bacillus is walled off, a chronic state of inflammation exists. The granuloma formed is a cavity of necrotic tissue. Lymphocytes. Lymphocytes arrive later at the site of injury. Their primary role is related to humoral and cell-mediated immunity. See Chapter 13. Chemical mediators. Mediators of the inflammatory response are outlined in Table 11.1. Complement system. The complement system is an enzyme cascade, C1 to C9, consisting of pathways to mediate inflammation and destroy invading pathogens. Major functions of the complement system are enhanced phagocytosis, increased vascular permeability, chemotaxis, and cellular lysis. All these activities are important mediators of the inflammatory response and healing. Cell lysis occurs when the final components create holes in the cell membranes and cause targeted cell death by membrane rupture. In autoimmune disorders, complement activation and the resulting inflammatory response can damage healthy tissue. Examples of this include rheumatoid arthritis and systemic lupus erythematosus. Prostaglandins and leukotrienes. When cells are activated by injury, the arachidonic acid in the cell membrane is rapidly converted to produce prostaglandins, PGs, thromboxane, and leukotrienes. Figure 11.2. PGs are considered pro-inflammatory. They are potent vasodilators, contributing to increased blood flow and edema formation. Some subtypes of PGs form when platelets are activated and can inhibit platelet and neutrophil aggregation. PGs have a significant role in sensitizing pain receptors to arousal by stimuli that would normally be painless. PGs have a pivotal role as pyrogens when stimulating the temperature-regulating area of the hypothalamus and producing a febrile response. See section on fever, page 158. Thromboxane is a powerful vasoconstrictor and platelet aggregating agent. It causes brief vasoconstriction and skin pallor at the injury site and promotes clot formation. It has a short half-life. The pallor soon gives way to vasodilation and redness, which is caused by PGs and histamine. Leukotrienes form the slow-reacting substance of anaphylaxis, or SRSA. SRSA constricts smooth muscles of the bronchi, causing narrowing of the airway, and increases capillary permeability, leading to airway edema. Exudate formation. Exudate consists of fluid and WBCs that move from the circulation to the site of injury. The nature and quantity of exudate depend on the type and severity of the injury and tissues involved. Table 11.2. Clinical manifestations. The local manifestations of inflammation include redness, heat, pain, swelling, and loss of function. Table 11.3 and Figure 11.3. Systemic manifestations include an increased WBC count with a shift to the left, malaise, nausea, and anorexia, increased pulse and respiratory rate, and fever. Leukocytosis results from the increased release of WBCs from the bone marrow. The causes of other systemic manifestations may be related to complement activation and the release of cytokines, soluble factors secreted by WBCs and other types of cells that act as intercellular and intracellular messengers. Some cytokines, e.g. interleukins, ILs, tumor necrosis factor, TNF, are important in causing fever and other systemic manifestations of inflammation. An increase in pulse and respiration follows the rise in metabolism because an increase in body temperature. Cytokines are discussed in Chapter 13. Fever. The release of cytokines triggers the onset of fever. Cytokines cause fever by initiating metabolic changes in the temperature-regulating center in the hypothalamus, Figure 11.4. The synthesis of PGs is the most critical metabolic change. PGs act directly to increase the thermostatic set point. The hypothalamus then activates the autonomic nervous system to stimulate increased muscle tone and shivering and decreased perspiration and blood flow to the periphery. Epinephrine, released from the adrenal medulla, increases the metabolic rate. The net result is fever. With the physiologic thermostat raised to a higher than normal temperature, the body increases heat production and conservation until the temperature reaches the new set point. At this point, the person feels chilled and shivers. The shivering response is the body's method of raising the body's temperature to the new set point. This seeming paradox is dramatic. The body is hot, yet the person piles on blankets and may go to bed to get warm. When the body temperature reaches the set point, the chills and warmth-seeking behavior cease. The released cytokines and the fever that they trigger activate the body's defense mechanisms. Beneficial aspects of fever include increased killing of microorganisms, increased phagocytosis by neutrophils, and increased proliferation of T cells. Higher body temperatures may enhance the activity of interferon, the body's natural virus-fighting substance. See Chapter 13. Types of inflammation. The basic types of inflammation are acute, subacute, and chronic. In acute inflammation, the healing occurs in 2 to 3 weeks and usually leaves no residual damage. Neutrophils are the predominant cell type at the site of inflammation. A subacute inflammation has the features of the acute process but lasts longer. For example, infective endocarditis is a smoldering infection with acute inflammation, but it lasts for weeks or months. See Chapter 36. Endocarditis is inflammation of the heart. Chronic inflammation lasts for weeks, months, or even years. The injurious agent persists or repeatedly injures tissue. The predominant cell types present at the site of inflammation are lymphocytes and macrophages. Examples of chronic inflammation include rheumatoid arthritis and osteomyelitis. The prolongation and chronicity of any inflammation may be the result of an alteration in the immune response, e.g. autoimmune disease, and can lead to physical deterioration. Nursing and interprofessional management, inflammation. Nursing implementation. Health promotion. The best management of inflammation is the prevention of infection, trauma, surgery, and contact with potentially harmful agents. This is not always possible. A simple mosquito bite causes an inflammatory response. Because occasional injury is inevitable, concerted efforts to minimize inflammation and infection are needed. Adequate nutrition is essential so that the body has the necessary factors to promote healing when injury occurs. A high fluid intake will replace fluid loss from perspiration. There is a 7% increase in metabolism for every 1 degree Fahrenheit increase in temperature above 100 degrees Fahrenheit, 37.8 degrees Celsius, or a 13% increase for every 1 degree Celsius increase. The increased metabolic rate increases a patient's need for calories. Early recognition of inflammation is essential so that the appropriate treatment can begin. This may be rest, drug therapy, or specific treatment of the injured site. Immediate treatment may prevent the extension and complications of inflammation. Acute care. Observation and vital signs. The ability to recognize the manifestations of inflammation is important. In the immunosuppressed person, e.g., taking corticosteroids, receiving chemotherapy, the classic manifestations of inflammation may be masked. The early symptoms of inflammation may be malaise or just not feeling well. Vital signs are important to note with any inflammation, especially when an infectious process is present. With infection, the temperature may rise and pulse and respiration rates may increase. Fever. An important aspect of fever management is determining its cause. Although many regard fever as harmful, an increase in body temperature is an important host defense mechanism. In the 17th century, Thomas Sydenham noted that fever is a mighty engine which nature brings into the world for the conquest of her enemies. Alright, pretty intense there, Thomas. Steps are often taken to lower body temperature to relieve anxiety of the patient and healthcare professionals. Because mild to moderate fever usually does little harm, imposes no great discomfort, and may help host defense mechanisms, antipyretic drugs are rarely essential to patient welfare. Moderate fevers, up to 103 degrees Fahrenheit or 39.4 Celsius, usually produce few problems in most patients. However, if the patient is very young or very old, is extremely uncomfortable, or has a significant medical problem, e.g., severe heart or lung disease or brain injury, antipyretic use should be considered. Fever in the immunosuppressed patient should be treated immediately with antibiotic therapy because infections can rapidly progress to septicemia. Neutropenia is discussed in Chapter 30 on page 631. Fever, especially if greater than 104 degrees Fahrenheit or 40 degrees Celsius, can damage body cells, and delirium and seizures can occur. At temperatures greater than 105.8 degrees Fahrenheit or 41 degrees Celsius, the hypothalamic temperature control center becomes impaired. Damage can occur to many cells, including those in the brain. Older adults have a blunted febrile response to infection. The body temperature may not rise to the level expected for a younger adult, or there may be a delay in the onset of the rise. The blunted response can delay diagnosis and treatment. By the time fever, as defined for younger adults, is present, the illness may be more severe. Patients who are taking nonsteroidal inflammatory drugs, NSAIDs, on a regular basis, e.g., for rheumatoid arthritis, may have a blunted febrile response. Although sponge baths increase evaporative heat loss, they may not decrease the body temperature unless the person received antipyretic drugs to lower the set point. Otherwise, the body will initiate compensatory mechanisms, e.g. shivering, to restore body heat. The same principle applies to the use of cooling blankets. They are more effective in lowering body temperature after the set point has been lowered. A nursing care plan for the patient with a fever, e-Nursing Care Plan 11.1, is available on the website for this chapter at blah 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 blah. Drug therapy. Drugs can decrease the inflammatory response and lower the body temperature, table 11.4. Aspirin blocks PG synthesis in the hypothalamus and elsewhere in the body. Acetaminophen acts on the heat-regulating center in the hypothalamus. Some NSAIDs, e.g. ibuprofen, Motrin, and Advil, have antipyretic effects. Corticosteroids are antipyretic through the dual action of preventing cytokine production and PG synthesis. This results in dilation of superficial blood vessels, increased skin temperature, and sweating. Antipyretics cause a sharp decrease in temperature. They should be given around the clock to prevent acute swings in temperature. Giving them intermittently can induce or perpetuate chills. When the antipyretic wears off, the body may initiate a compensatory involuntary muscular contraction, i.e. chill, to raise the body temperature back up to its previous level. We can prevent this unpleasant side effect by giving them regularly at 2 to 4 hour intervals. Antihistamine drugs may be used to inhibit the action of histamine. Antihistamines are discussed in chapters 13 and 26. RICE. Rest, ice, compression, and elevation is a key concept in treating soft tissue injuries and related inflammation. Rest. Rest helps the body use its nutrients and O2 for the healing process. The repair process is facilitated by allowing fibrin and collagen to form across the wound edges with little disruption. Cold and heat. Cold application is usually appropriate at the time of the initial trauma. Use promotes vasoconstriction and decreases swelling, pain, and congestion from increased metabolism in the area of inflammation. Heat may be used later, e.g. after 24 to 48 hours, to promote healing by increasing the circulation to the inflamed site and subsequent removal of debris. Heat is used to localize the inflammatory agents. Warm, moist heat may help debride the wound site if necrotic material is present. Compression and immobilization. Compression counters the vasodilation effects and development of edema. Compression by direct pressure over a laceration occludes blood vessels and stops bleeding. Compression bandages support injured joints when tendons and muscles are unable to provide support on their own. Assess distal pulses and capillary refill before and after application of compression to evaluate whether compression has compromised circulation, e.g. pale color of skin, loss of feeling. Immobilization of the inflamed or injured area promotes healing by decreasing the tissue's metabolic needs. Immobilization with a cast or splint supports fractured bones and prevents further tissue injury from sharp bone fragments that could sever nerves or blood vessels, causing hemorrhage. As with compression, evaluate the patient's circulation after application and at regular intervals. Swelling can occur within the closed space of a cast and compromise circulation. Elevation. Elevating the injured extremity above the level of the heart reduces the edema at the inflammatory site by increasing venous and lymphatic return. Elevation helps reduce pain associated with blood engorgement at the injury site. Elevation may be contraindicated in patients with significantly reduced arterial circulation. Healing process. The last phase of the inflammatory response is healing. Healing includes two major components, regeneration and repair. Regeneration is the replacement of lost cells and tissues with the cells of the same type. The ability of cells to regenerate depends on the cell type. Table 11.5. Repair is healing, with connective tissue replacing lost cells. Repair is the more common type of healing and usually results in scar formation. Repair is a more complex process than regeneration. Most injuries heal by connective tissue repair. Repair healing occurs by primary, secondary, or tertiary intention. Figure 11.5. Primary intention. Primary intention healing takes place when wound margins are neatly approximated, as in a surgical incision or a paper cut. A continuum of processes is associated with primary healing. Table 11.6. These processes include three phases. Initial phase. In the initial inflammatory phase, the edges of the incision are aligned and sutured or stapled in place. The incision area fills with blood from the cut blood vessels, blood clots form, and platelets release growth factors to begin the healing process. This forms a matrix for WBC migration. An acute inflammatory reaction occurs. The area of injury is composed of fibrin clots, erythrocytes, neutrophils, dead and dying, and other debris. Macrophages ingest and digest cellular debris, fibrin fragments, and red blood cells, RBCs. Extracellular enzymes derived from macrophages and neutrophils help digest fibrin. As the wound debris is removed, the fibrin clot serves as a meshwork for future capillary growth and migration of epithelial cells. Granulation phase. The granulation phase is the second step. The components of granulation tissue include proliferating fibroblasts, proliferating capillary sprouts, angioblasts, various WBCs, exudate, and loose semifluid ground substance. Fibroblasts are immature connective tissue cells that migrate into the healing site and secrete collagen. In time, the collagen is organized and restructured to strengthen the healing site. At this stage, it is called fibrous or scar tissue. During the granulation phase, the wound is pink and vascular. Numerous red granules, young budding capillaries, are present. At this point, the wound is friable, at risk for dehiscence, figure 11.6, and resistant to infection. Dehiscence is basically when something like that just busts open. Surface epithelium at the wound edges begins to regenerate. In a few days, a thin layer of epithelium migrates across the wound surface in a one-cell thick layer until it contacts cells spreading from the opposite direction. The epithelium thickens and begins to mature, and the wound now closely resembles the adjacent skin. In a superficial wound, re-epithelialization may take 3 to 5 days. Maturation phase and scar contraction. The maturation phase, during which scar contraction occurs, overlaps with the granulation phase. It may begin 7 days after the injury and continue for several months or years. This is the reason abdominal surgery discharge instructions limit lifting for up to 6 weeks. Collagen fibers are further organized and the remodeling process occurs. Fibroblasts disappear as the wound becomes stronger. The active movement of the myofibroblasts causes contraction of the healing area, helping to close the defect and bring the skin edges closer together. A mature scar is then formed. In contrast to granulation tissue, a mature scar is virtually avascular and pale. The scar may be more painful at this phase than in the granulation phase. Secondary intention. Wounds that occur from trauma, injury, and infection have large amounts of exudate and wide irregular wound margins and extensive tissue loss. These wounds may have edges that cannot be approximated, brought together. The inflammatory reaction may be greater than in primary healing. This results in more debris, cells, and exudate. We may have to clear debris or debris before healing can take place. The process of healing by secondary intention is essentially the same as healing by primary intention. The major differences are the greater defect and the gaping wound edges. Healing and granulation take place from the edges inward and from the bottom of the wound upward until the wound is filled. There is more granulation tissue, and the result is a much larger scar. Tertiary intention. Tertiary intention, delayed primary intention. Healing occurs with delayed suturing of a wound in which 2 layers of granulation tissue are sutured together. This occurs when a contaminated wound is left open and sutured closed after the infection is controlled. It also occurs when a primary wound becomes infected, is opened, allowed to granulate, and then sutured. Tertiary intention usually results in a larger and deeper scar than primary or secondary intention. Wound classification. A wound is a break or opening into the skin. Wounds often occur because of accidents or injuries. Types of wounds can range from minor scrapes to deep wounds involving bones, blood vessels, and nerves. Identifying the cause of a wound is essential to classifying the wound properly. Wounds can be classified by their cause, surgical or non-surgical, acute or chronic, or the depth of tissue affected, superficial, partial thickness, or full thickness. A superficial wound involves only the epidermis. Partial thickness wounds extend into the dermis. Full thickness wounds have the deepest layer of tissue destruction. They involve the subcutaneous tissue and sometimes extend into the fascia and underlying structures, including muscle, tendon, or bone. A skin tear is a wound caused by shear, friction, and/or blunt force resulting in separation of skin layers. A skin tear can be partial thickness or full thickness. This type of wound is common, especially in older adults and critically or chronically ill adults. Complications of healing. Certain factors can interfere with wound healing and lead to complications. Table 11.7. Nursing and interprofessional management, wound healing. Nursing assessment. The first step in wound care is to carefully assess and document the characteristics of the wound and surrounding area. This includes the location, size, longest length and widest width, depth, undermining and tunneling, wound margin, e.g. normal, macerated, erythema, and wound base, e.g. eschar, slough, exudate. There are several ways to measure a wound. One way is shown in Figure 11.9. Record the consistency, color, and odor of any drainage and report if abnormal for the situation. Staphylococcus and Pseudomonas are common organisms that cause purulent draining wounds. Thoroughly assess the wound on admission, or first clinic visit, and on a regular basis thereafter. In healthy people, wounds heal at a normal, predictable rate. Assess for factors that may delay wound healing and contribute to chronic non-healing wounds. Table 11.8. If deterioration in the wound occurs, you need to assess and document changes more often. Chronic wounds are those that do not heal within the normal time, around 3 months. If a wound does not heal as expected, assess and identify factors that may delay healing. Refer the patient to an HCP specializing in wound management. Time does not heal all wounds. While caring for patients during the healing process, you need to continually assess for complications, e.g. infection, associated with healing. Table 11.7. Nursing implementation. The type of wound management and dressings needed depend on the type, extent, and characteristics of the wound and the phase of healing. The purposes of wound management include 1. Protecting a clean wound from trauma so that it can heal normally. 2. Cleaning a wound to remove any dirt and debris from the wound bed. And 3. Treating infection to prepare the wound for healing. Clean wounds. Superficial skin injuries may only need cleansing. Material used to close wounds include adhesive strips, e.g. Steri-strips, butterflies, sutures, stitches, staples, and tissue adhesives, fibrin sealants. We use adhesive strips instead of sutures for some injuries because they decrease scarring and it is easier to care for them. Sutures are used to close wounds because suture material provides the mechanical support needed to sustain closure. A wide variety of suturing materials are available. Tissue adhesives are a biologic adhesive that can be applied alone or with sutures or tape. A dressing material that keeps the wound surface clean and slightly moist is best to promote epithelialization. For wounds that heal by primary intention, it is common to cover the wound or incision with a dry, sterile dressing. It is removed as soon as the drainage stops or in 2 to 3 days. Medicated sprays that form a transparent film on the skin may be used for dressings on a clean incision or injury. Transparent film or adhesive semi-permeable dressings, e.g. Opsite, Tegaderm, are occlusive dressings that are permeable to oxygen. The wound is then usually covered with a sterile dressing. Sometimes an HCP will leave a surgical wound uncovered or remove the dressing within 48 hours after surgery. Examples of types of wound dressings are described in Table 11.9. Clean wounds that are granulating and re-epithelializing should be kept slightly moist and protected from further trauma until they heal naturally. Do not let a wound that has the potential to heal dry out. Dryness is an enemy of wound healing. Airing out a wound is a great mistake. Wounds need a moist environment to heal. Unnecessary manipulation during dressing changes may destroy new granulation tissue and break down fibrin formation. Topical antimicrobials and antibactericidals, e.g. povidone iodine, betadine, Dakin's solution, sodium hypochlorite, should be used with caution in wound care because they can damage new epithelium of healing tissue and delay healing. They should never be used in a clean, granulating wound. Sometimes drains are inserted into the wound to help remove fluid. The Jackson-Pratt drain is a suction drainage device consisting of a flexible plastic bulb connected to an internal plastic drainage tube. Figure 11.10. Contaminated wounds. If the wound is contaminated, it must be converted into a clean wound before healing can occur normally. Debridement of a wound that has debris or dead tissue may be needed. Another option is absorptive dressings. They can be used to absorb exudate and clean the wound surface. These dressings work by drawing excess drainage from wound surface. The amount of wound secretions determines the number of dressing changes. In hydrocolloid dressings, such as Duoderm, the inner part of the dressing interacts with the exudate, forming a hydrated gel over the wound. When the dressing is removed, the gel separates and stays over the wound. The wound must be cleansed gently to prevent damage to newly formed tissue. We can leave these dressings in place for up to 7 days or until leakage occurs around the dressing. Debridement is done to remove dead tissue. The debridement method used depends on the amount of debris and the condition of the wound tissue. Table 11.10. Negative pressure wound therapy. Negative pressure wound therapy, Npwt, is used to treat acute and chronic wounds. A vacuum source creates continuous or intermittent negative pressure inside the wound to remove fluid, exudates, and infectious materials to prepare the wound for healing and closure. We do not know exactly how Npwt promotes healing. It is thought that Npwt pulls excess fluid from the wound, reduces bacterial load, and encourages blood flow into the wound base. Npwt systems consist of a vacuum pump, drainage tubing, a foam or gauze wound dressing, and an adhesive film dressing that covers and seals the wound. In Npwt, the wound is cleansed and a gauze or foam dressing is cut to the dimensions of the wound. A large occlusive dressing is applied, with a small hole made over the gauze or foam dressing where the tubing is attached. Figure 11.11. The tubing is connected to a pump, which creates a negative pressure in the wound bed. Monitor the patient's serum protein levels and fluid and electrolyte balance because of losses from the wound. Also, monitor the patient's coagulation studies, platelet count, prothrombin time, PT, and partial thromboplastin time, PTT. Hyperbaric oxygen therapy. Hyperbaric O2 therapy, HBOT, is the delivery of O2 at increased atmospheric pressures. It can be given topically by creating a chamber around the injured limb. It also can be given systemically with the patient in an enclosed chamber, receiving 100% O2 at 1.5 to 3 times the normal atmospheric pressure. HBOT allows O2 to diffuse into the serum, rather than RBCs, and be transported to the tissues. By increasing the O2 content in the serum, HBOT moves the O2 past narrowed arteries and capillaries where RBCs cannot go. In addition, high O2 levels stimulate angiogenesis, production of new blood vessels, kill anaerobic bacteria, and increase the killing power of WBCs and certain antibiotics, e.g. fluoroquinolones and aminoglycosides. HBOT accelerates granulation tissue formation and wound healing. Most systemic treatments last from 90 to 120 minutes. The number of treatments is highly variable, from 10 to 60, depending on the condition being treated. Drug therapy. Platelet-derived growth factor is released from the platelets and stimulates cell proliferation and migration. Becapleramin, Granex, a recombinant human platelet-derived growth factor gel, actively stimulates wound healing. It is used to treat foot injuries in patients with diabetes, see Chapter 48. Becapleramin should be used only when the wound is free of dead tissue and infection. It should not be used if cancer is suspected in the wound. Nutritional therapy. Special nutritional measures promote wound healing. A high fluid intake is needed to replace fluid loss from perspiration and exudate formation. An increased metabolic rate intensifies water loss. Persons at risk for wound healing problems are those with malabsorption problems, e.g. Crohn's disease, GI surgery, liver disease, deficient intake or high energy demands, e.g. cancer, major trauma or surgery, sepsis, fever, and diabetes. Undernutrition puts a person at risk for poor healing. A diet high in protein, carbohydrate, and vitamins with moderate fat intake is necessary to promote healing. Protein is needed to correct the negative nitrogen balance resulting from the increased metabolic rate. It is also needed for the synthesis of immune factors, WBCs, fibroblasts, and collagen, which are the building blocks for healing. Carbohydrates are needed to meet the increased metabolic energy required for healing. If there is a carbohydrate deficit, the body will break down protein for the needed energy. Fats help in the synthesis of fatty acids and triglycerides, which are part of the cellular membrane. Vitamin C is needed for capillary synthesis and collagen production by fibroblasts. The B-complex vitamins are necessary as coenzymes for many metabolic reactions. If a vitamin B deficiency develops, a disruption of protein, fat, and carbohydrate metabolism will occur. Vitamin A aids in epithelialization. It increases collagen synthesis and tensile strength of the healing wound. If the patient is unable to eat, enteral feedings and supplements should be the first choice if the GI tract is functional. Parenteral nutrition is indicated when enteral feedings are contraindicated or not tolerated. Enteral and parenteral nutrition are discussed in Chapter 39. Infection prevention and control. You and the patient must scrupulously follow aseptic procedures, including hand washing, for keeping the wound free from infection. Do not allow the patient to touch a recently injured area. The patient's environment should be free as possible from contamination from items introduced by roommates and visitors. Some patients may receive prophylactic antibiotics. If an infection develops, a culture and sensitivity test is done to determine the organism and the most effective antibiotic for that specific organism. Obtain the culture before the first dose of antibiotic is given. We can obtain cultures by needle aspiration, tissue culture, or swab technique. HCPs perform needle and tissue punch biopsies. As a nurse, you can obtain cultures using the swab technique. This is done using Levine's technique, which involves rotating a culture swab over a cleansed 1 centimeter squared area near the center of the wound. Use enough pressure to extract wound fluid from deep tissue layers. Take a culture of the clean tissue because exudate and necrotic tissue will not provide an accurate sample. The sample must be sent to a laboratory within 1 hour. Physiologic implications. The patient may be distressed at the thought or sight of an incision or wound because of fear of scarring or disfigurement. Drainage and odor from a wound often cause alarm. The patient needs to understand the healing process and normal changes that occur as the wound heals. When changing a dressing, avoid inappropriate facial expressions that may alert the patient to problems with the wound or raise doubts about your ability to care for it. Wrinkling your nose may convey disgust to the patient. Be careful not to focus on the wound to the extent that you are not treating the patient as a total person. Patient teaching. Because patients are being discharged earlier after surgery, and many have surgery as outpatients, it is important that the patient and caregiver know how to care for a wound and perform dressing changes. Wound healing may not be complete for 4 to 6 weeks or longer. Emphasize the importance of adequate rest and good nutrition throughout this time. Physical and emotional stress should be minimal. Observing the wound for complications such as contractures, adhesions, and secondary infection is important. Teach the patient and caregiver the signs and symptoms of infection. Have them note changes in the wound color and amount of drainage. Teach the patient to notify the HCP of any signs of abnormal wound healing. Drugs may be given for a time after recovery from the acute infection. Review drug-specific side effects and adverse effects with the patient and caregiver, as well as methods to prevent side effects, e.g. taking with food. Teach the patient to contact the HCP if any of these effects occur. Discuss the need to complete the entire course of therapy. For example, a patient who needed to take an antibiotic for 10 days decides to stop taking the drug after 5 days because of absent symptoms. However, the organism was not entirely eliminated. It becomes resistant to the antibiotic, and the patient develops a more severe infection. Pressure injuries. Etiology and Pathophysiology. A pressure injury is localized damage to the skin and/or underlying soft tissue. It usually occurs over a bony prominence or is related to a medical or other device. The injury occurs because of intense and/or prolonged pressure or pressure in combination with shear. The most common site for pressure injuries is the sacrum, with heels being second. Factors that influence the development of pressure injuries include the amount of pressure, intensity, length of time the pressure is exerted on the skin, duration, and the ability of the patient's tissue to tolerate the externally applied pressure. Other factors that contribute to pressure injury formation include shear, pressure exerted on the skin when it adheres to the bed and the skin layers slide in the direction of body movement, e.g. when pulling the patient up in bed. And excessive moisture increases risk for skin breakdown. The tolerance of soft tissue for pressure and shear are affected by microclimate, nutrition, perfusion, comorbidities, and condition of the soft tissue. Factors that put a patient at risk for developing a pressure injury are outlined in Table 11.11. Let's take a look at that. Risk factors for pressure injuries. Advanced age, anemia, contractures, critically ill cared for in critical care setting, diabetes, fever, friction, rubbing of surfaces together, hip fracture, immobility, incontinence, long and/or extensive surgical procedure, low diastolic blood pressure less than 60 milligrams mercury, major trauma, mental deterioration, neurologic disorders, pain, peripheral vascular disease, spinal cord injury. Patients at risk include those who are older, incontinent, unable to reposition, or unaware of the need to reposition, e.g. spinal cord injury, and bed or wheelchair bound. Clinical manifestations. The manifestations of pressure injuries depend on the extent of the tissue involved. The injury can present as intact skin or an open injury and may be painful. We stage pressure injuries based on the visible or palpable tissue in the injury bed. Table 11.12 shows the pressure injury stages based on the National Pressure Injury Advisory Panel, NPwt. If the pressure injury becomes infected, the patient may have signs of infection, e.g. leukocytosis, or fever. The pressure injury may increase in size, odor, and drainage, have necrotic tissue, and be indurated, warm, and painful. Untreated pressure injuries may lead to cellulitis, spreading of inflammation to subcutaneous or connective tissue, chronic infection, sepsis, and possibly death. The most common complication of a pressure injury is recurrence. Therefore, it is important to note the location of previously healed pressure injuries on a patient's admission assessment. Nursing and interprofessional management, pressure injuries. In 1859, Florence Nightingale wrote, "If he has a bedsore, it is generally not the fault of the disease, but of the nursing." Her comment emphasizes the critical role that nurses have in prevention and treatment of pressure injuries. Nursing and interprofessional management are discussed together because the activities are interrelated. In addition to the nurse, other members of the health team, such as the wound care specialist, plastic surgeon, dietitian, physical therapist, and occupational therapist, can provide valuable input into the complex treatment necessary to prevent and treat pressure injuries. Nursing assessment. Assess patients for pressure injury risk initially on admission and at periodic intervals based on the patient's condition. Conduct a thorough head-to-toe assessment on admission to identify and document any pressure injuries. After admission, conduct periodic reassessments of the skin and wounds. To do a risk assessment, use a validated assessment tool, such as the Braden Scale, available at bradenscale.com. Knowing the level of risk can help determine how aggressive preventative measures should be. Identification of skin changes may be hard in patients with dark skin. Table 11.13 presents techniques to help assess darker skin. Subjective and objective data that should be obtained from a person with or at risk for a pressure injury are outlined in Table 11.14. Nursing diagnoses. Nursing diagnoses for the patient with a pressure injury may include impaired tissue integrity, risk for infection. Planning. The overall goals are that the patient with a pressure injury will 1. Have no deterioration of the wound, 2. Not develop an infection in the pressure injury, 3. Have healing of pressure injuries, and 4. Have no recurrence. Nursing implementation. Health promotion. The primary nursing responsibilities are 1. Identifying patients at risk for developing pressure injuries, Tables 11.11 and 11.14, and 2. Implementing pressure injury prevention strategies for those who are at risk. Prevention is the best treatment for pressure injuries. Implementing evidence-based pressure injury prevention programs can reduce the occurrence of healthcare-acquired pressure injuries. In the past, the standard was to turn and reposition patients every 2 hours. However, this policy is not evidence-based. Individualized time schedules and frequency based on risk factors, patient's overall condition, and type of mattress and support surface. For example, some high-risk patients may need to be turned and repositioned every hour, while others at lower risk may need to be turned and repositioned only every 3 to 4 hours. Acute care. Care of a patient with a pressure injury requires wound care and support measures of the whole person, including adequate nutrition, pain management, control of other medical conditions, and redistributing pressure. Both conservative and surgical strategies are used in the treatment of pressure injuries, depending on the stage and condition of the injury. Once a pressure injury has developed, initiate interventions based on the injury characteristics, e.g. stage, size, location, amount of exudate, type of wound, presence of infection or pain. and the patient's general status, e.g. nutritional state, age, cardiovascular status, level of mobility. Carefully document the size of the pressure injury. A wound measuring card or tape can be used to note the injury's maximum length and width in centimeters. To find the depth of the injury, take a sterile cotton-tipped applicator and soak it with saline. Gently place it into the deepest part of the injury, and then measure the length of the part of the applicator that probed the injury. Documentation of the healing wound can be done using several available pressure injury healing tools, such as the Npwt Pressure Injury Scale for Healing, PUSH tool. Some agencies require that pictures of the pressure injury be taken initially and at regular intervals during treatment. The informatics box has suggestions for digital imaging. Pressure injuries generally fall under the category of healing by secondary intention. Care may involve debridement, wound cleaning, application of a dressing, and offloading pressure. It is important to choose the right pressure redistributing techniques, e.g. mattress replacement, mattress overlay, integrated bed system, seat cushion overlay, to move pressure off areas of pressure injury. Whenever possible, do not turn the patient onto a body surface that has blanchable erythema. Massage is contraindicated in the presence of acute inflammation and where there is the possibility of damaged blood vessels or fragile skin. Sliding down in bed causes shear. Encourage patients to reposition themselves by lifting rather than sliding and to use a trapeze if needed. Use lift sheets to move patients up in bed or to transfer them. A pressure injury that has necrotic tissue or eschar, except for dry, stable necrotic feet or heels, should have a tissue removed by surgical, mechanical, enzymatic, or autolytic debridement methods. Once the pressure injury has been successfully debrided and has a clean granulating base, the goal is to provide a wound environment that supports moist wound healing and prevents disruption of the newly formed granulation tissue. Reconstruction of the pressure injury site by surgical repair, including skin grafting, skin flaps, musculocutaneous flaps, or free flaps, may be necessary. Clean pressure injuries with non-cytotoxic solutions, e.g. normal saline, that do not kill or damage cells, especially fibroblasts. Cytotoxicity is a concern when applying a topical agent to a pressure injury. However, if there is a delay in healing due to infection, then antimicrobial use, e.g. sodium hypochlorite, Dehiscence solution, povidone iodine, cadexamer iodine, overrides the toxicity concern. Hydrogen peroxide is cytotoxic and should not be used. It is important to use enough irrigation pressure, 4 to 15 psi, to adequately clean the pressure injury without causing trauma or damage to the wound. You can achieve this pressure using a 30 milliliter syringe and a 19 gauge needle. After the pressure injury has been cleansed, cover it with an appropriate dressing. Keep a pressure injury slightly moist rather than dry to enhance re-epithelialization. Some factors to consider when choosing a dressing are maintaining a moist environment, preventing the wound from drying out, ability to absorb the wound drainage, location of the wound, amount of caregiver time required to change the dressing, cost of the dressing, presence of infection, clean versus sterile dressings, and care delivery setting. Dressings are described in Table 11.9. Stages 2 through 4 pressure injuries are considered contaminated or colonized with bacteria. Remember that in people who have chronic wounds or are immunocompromised, the signs and symptoms of infection, purulent exudate, odor, erythema, warmth, tenderness, edema, pain, fever, high WBC count, may not be present even when the pressure injury is infected. Maintaining adequate nutrition is an important nursing responsibility for the patient with a pressure injury. Often the patient is debilitated and has a poor appetite secondary to inactivity. Oral feedings should be adequate to meet the patient's nutritional requirements. The caloric intake needed to correct and maintain nutritional balance may be 30 to 35 calories per kilogram per day and 1.25 to 1.50 grams of protein per kilogram per day. Enteral feedings can supplement oral feedings. When oral and enteral feedings are inadequate, parenteral nutrition consisting of amino acid and glucose solutions is used. Parenteral and enteral nutrition are discussed in Chapter 39. Ambulatory care. Pressure injuries affect the quality of life of patients and their caregivers. Because pressure injuries often recur, teaching prevention techniques to the patient and caregiver is extremely important. Table 11.15. A 6th grade level version of the patient guide to pressure injury prevention is available for use in patient teaching at blah 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 blah. The caregiver needs to know the cause of pressure injuries, prevention techniques, early signs, nutritional support, and care techniques for actual pressure injuries. Because the patient with a pressure injury often needs extensive care for other health problems, it is important that the nurse support the caregiver with the added responsibility for pressure injury treatment. E-Nursing Care Plan 11.2, available at blah 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 blah, outlines the care for the patient with a pressure injury. Evaluation. The expected outcomes are the patient with a pressure injury will have healing of pressure injury and intact skin with no further breakdown. And that's it for Chapter 11.